is, sorry, Val, are you,
Yes, just proceed.
okay,
I think
got
you'll
it.
just talk through your presentation.
That sounds good. No problem. I'm happy to do that as well. Yeah, so some of the perspectives that we're having around AI adoption in Africa are coming from this body of work, and that's what we're going to speak about today. Whether AI works in health has largely been settled. That ship has sailed quite seriously in the continent. The questions that we are faced with more and more is how does it responsibly get adopted? That gap between technical capability and real world adoption is really where we want to spend our time today. So for those who are meeting with us for the first time, Spindle is a human-centered design and innovation company, and we work across the continent. At the heart of our work is a fairly simple belief, and that is that good ideas create value, typically when they work in the realities of people's lives. So we tend to go beyond the product itself, though we do focus on products, and we look at the people, how people are expected to actually use it, the behaviors that have to change, how the broader system actually engages with different products and services. Um, and in AI-enabled health specifically, we go beyond designing the model and designing really around the care decisions, the moments of use. And that's an increasingly important lens to us because AI is no longer sitting around the edges of healthcare. Um, it is moving closer into clinical decisions, right? Um, can you can you still hear me?
Yes, I can hear you and I can see the screen.
Oh, okay. Got it. So things like patient communication, triage, operational flows, and we see funding ambitions to, connect 1,000 clinics and to reach 10,000 patients, and funding is moving in that direction. So the output is no longer just an output. We've helped where AI used to help with back office analytics, about output was really inconvenient. But when we talk about some of these scenarios like clinical decision support or triage referral operations, the stakes are a little bit higher. So technical performance in our point of view, it matters enormously, but it can't be the only thing we design for. And that's why we think the conversation around AI is really beginning to mature. Early conversations were about, can AI do this? Can it classify an image? Can it read an X-ray or answer a patient? And for the most part, those questions, that ship has sailed. We're no longer asking those questions. We know it's possible. In fact, we're more scared that AI has swung to the other end of the pendulum and is doing things that we can't quite control. But that shift to can this actually responsibly be adopted in care settings significantly changes the design brief for us. The question is really one that we see teams grappling with. And so here you have to ask yourself, have we chosen a healthcare problem that really matters? And at Spindle, we tend to say that technology is not the only solution to every problem. If technology is a hammer, sometimes it's looking for a nail, and sometimes adding technology to a poorly understood problem, it simply gives us a more complicated problem, not a more sophisticated solution. So adoption isn't what comes after the product. It's actually something that we have to think about from the very beginning, and we see this represented in our work. Are capable, and so we design a thinking across these three levels. Um, a capable model is very necessary, but value depends on the system around that model. And here we're thinking about designing in this space at these three levels. Where we spend most of our time in our conversation is in the first, the capability, the prediction. This is
Okay,
this is what the AI
Anita,
can technically. typically do. Sorry?
For example.
Oh, okay. And
Okay.
it's where our investor
Yeah, it's a
decks
full
tend to
picture.
live these days.
Mm-hmm.
And then there's the moment.
Uh,
This is like the actual clinical encounter with the patient interaction, or where an AI input output meets a human need. This two areas are the places where we tend to spend the most of our time and effort. The system is the workflow, the incentives, where does accountability come from? Because imagine that AI correctly flags a high risk patient. What has happened there is really the model has worked great. Then we have to ask ourselves a bunch of questions on top of that. Did the right person see the alert? Did they trust it? Did they know what action to take? Did they have time and authority to act? And that's where moment and system come into play. And something that we've noticed over time, that we're spending the bulk of our energy and our resources in one of these areas while neglecting some of the others. And really, we should be shifting and balancing our energy across the three, which is really why we say that capability is created by the model, but value is created or lost at the moment of use. An accurate model with a broken moment can sometimes be even more harmful or worse than no AI at all. We're talking about a clinical setting, and I'd like to see AI move beyond the pitch decks and the model and the capability to really saving lives, because that's what's at stake. And most of the failures we've seen aren't model failures. Yes, the models hallucinate, and we still have technical things to work through. They're really more failures in the moments and failures in the system. An underappreciated fact about AI that we're grappling with ourselves quite a lot, because the way we design for this product, the way we do scale has radically shifted. It's really that AI doesn't simply sit inside an existing workflow. When AI enters a workflow, it tends to rewrite it. So if you haven't actually mapped out and understood your workflow, unfortunately, AI can easily take you for a ride, because it tends to rearrange work. We're moving past simply automating tasks and thinking about how the things that AI redistributes. And we've seen five things that it touches and influences quite strongly. It redistributes attention, and it doesn't quite quietly do this, right? It tends to change the arrangement and relationship in these settings. What becomes visible or urgent? Judgment and who is making judgment calls. What work disappears or shifts, human intervention and how that's actually done, and where accountability sits. The redistribution is not automatically harmful. In fact, it might be where value comes from, but it does create design consequences, whether we plan for them or not. And one of the things we encourage builders and founders and folks that are in this space to do is to see those design consequences a lot more intentionally, know the things that we're leaving in our product or system or service creation process, and the things that we are not actually touching. Because and places that we look for these consequences are in five places. We've kind of distilled this from a number of engagements, and it's still a work in progress. I'd actually love to hear from this group, other places where you've seen adoption is won or lost. It's a working framework that we use to assess whether AI can survive contact with a real world setting. The first really is task fit, and the question here we're asking is, does this tool solve a problem that matters enough, often enough, to earn a place in the daily flow of care? Innovation for the sake of innovation can be interesting, but remember that the stakes are at saving lives. Sometimes tools that solve everyday frustrations in a day-to-day context will win over technically brilliant tools that solve a very rare problem. Remember, not every problem needs AI, and not every technically possible intervention deserves a place in care delivery. So just because we can do it doesn't always mean that we have to. And yes, sometimes we do get into trouble for saying that to some of our partners, but I think it's something we do have to consider with some of this technology. A second is workflow fit. Does it reduce effort? Does it add another screen for the sake of adding one or an interface? If your AI means that the clinician has to open, I don't know, a second app or during a 5-minute consultation, has it eased their burden or increased their burden? What has it actually done to their workflow? And how is the person that's receiving that tool actually experiencing it? The third is a pretty big one in the African context because we have the advantage of actually designing for some of the most difficult settings, places, local languages, different clinical protocols, infrastructure that's challenging to work with oftentimes, connectivity that goes out at the wrong moment. A model trained on a US teaching hospital doesn't automatically translate to a clinic in Turkana. And that context really, really matters. Knowing what context we are introducing these tools into and whether we can sustain these tools in those contexts for a long time is a strong consideration for adoption. Trust is really whether folks can understand it and adopt it. And system fit, we touch here on things like who maintains the tool, who governs it. This is also the place to talk about commercial sustainability. The evidence from a pilot, if we take all of these things, should tell us more than whether the model performed or not. It should tell us things like, did people use it? Did it improve a decision? Did it create a new burden? Were some groups better served than others? Are we creating inequality and disparities? Can the organization actually sustain it? And it's a test for conditions that are required for routine use. In our world, we tend to talk a lot about product market fit. It's a concept that I would bring into this adoption conversation. I won't go through these 6 principles, but we've largely translated a lot of that work into these 6 principles. And I won't read every box, but they broadly fall into 3 ideas. The first idea is designing the decision and the work. Don't begin everything the model is capable of doing. These models can do a lot. Sometimes we can sit with ChatGPT and they gaslight us very well. You look very nice. It doesn't have eyes, but it will tell you what you want to hear if you let it. Models are capable of a lot. Sometimes they're also very confidently wrong. So begin with the decision that needs to become better. If that decision we think can be made better without the intervention of AI, go for it. That is a viable pathway. What information, who needs to make a decision, that decision? What information does that person need? What happens if the decision is wrong? And then design the work, not just the interface. The second category here is around designing intervention and failure. We tend to think about pathways for success, but not often do we think about scenarios for failure and what kind of uh, safeguards we have if something goes wrong, specifying steps where a human can step in with or without authority, and planning for missing data or connectivity. And the third category is around trust and learning. Our work has is largely distilled into these principles, and the way we do this is really by researching a lot of these contexts, designing for some of these principles, and continuously iterating. It's a loop that doesn't quite end, even though that it can feel like quite a lot. So the message I would like to leave us with is don't design just for the intelligence. The intelligence is there. It's available to all of us. Design for the conditions that make it usable, safe, and trusted. We can't control every condition within a care system, But something that we can do is to understand those conditions intentionally. We can do the work of making hidden assumptions visible. We can design better workflows, clearer human roles, safer failure pathways, and even stronger mechanisms for learning. Moving from this idea of moving from pilot to practice, therefore, in our opinion, isn't just an engineering problem. It's a product design challenge, it's a system challenge, it's an implementation challenge. And those questions can't just be answered by product teams alone. It requires founders who understand the problem, clinicians who understand the reality of care, partners and investors who are able and willing to sustain the pathway. Um, and that's actually why I'm very excited for the conversation that follows and the panelists that will be sharing from their experience. One thing that we are doing in response to this is we understand many folks are building right now. And so we're opening up the Spindle Health AI Builder Lab. It's a really small cohort for teams building health AI solutions in Africa. And the lab is designed to help sharpen the problem, to test assumptions, to validate some things really early, to understand workflows really deeply, and then prepare for real world piloting. We are keeping it intentionally small, just 5 slots, because this kind of work at this point for us needs quite a lot of depth. So if you are building in this space, the expressions for interest are open. And if you want to partner in shaping this work, we'd also love to hear from you, and you can get in touch as well. So thank you.
Great. Thank you so much, Maureen. Very amazing takeaways there. I wish I could go through all of them, but my main takeaway is that success for these AI health solutions begins long before even the model is built. It's about thinking about who is going to use the solutions, the healthcare provider, is it the clinician, the patient at the end. So thank you so much for those insights, for sharing about the Builder Lab that Spindle Design is starting. So thank you so much. Now we will just move into the panel discussion. I will just ask Kelvin to share the slides. But in the meantime, we are joined by three experienced panelists. We have Dr. Ojwang from AAR Hospital. We also have Dr. Adudant, who is a founder at Kia Health. We also have Emmanuel Momanyi from Vilcro Africa. I will just let each of you introduce yourself shortly. We will start with Dr. Adudant, Steve Adudant. The floor is yours. Kindly just a brief introduction into yourself and into Gear Health in about a minute, and then we'll move to the other panelists and then just dive right into the panel discussion. Over to you, Dr. Adudant.
Okay, great. Yeah, thanks, Valentine. I hope I'm audible enough.
Yes, you are.
Excellent. So my name is Steve Adudant, and I'm passionate about health and wellness. And I work with Gear Health, and Gear Health, our main job is easy, is to make it people to enjoy being healthy and feeling well. And we do this so that people do not have to sacrifice their lifestyle to the extent that they want to be healthy. So just sorting out the main issues of access, affordability, and also just lifestyle change. And we do this in virtual format and also in personal format. Thank you.
Thank you so much, Dr. Adudant. We'll move to Dr. Stephen Ojwang.
Yeah, thank you, Valentine, and great presentation there. So my name is Dr. Stephen Ojwang. Passionate about healthcare and healthcare access, especially being in Africa, where a lot of people have to travel very far to access quality healthcare. And I'm glad to be having this conversation because now with AI, we've shortened the journey for more than 70% of the population in Africa who have had to travel for over 2 hours to access quality healthcare. That's a message I preach as a passionate healthcare access champion. I also serve as the head of department of radiology at AR Hospital, and really glad and honored to be here. Thank you.
Thank you so much, Dr. Ojwang. Over to you, Emmanuel.
Great. Thank you, Val. Hi, everyone. Emmanuel Momanyi here. It's a pleasure to see all of you that have attended. And thanks a lot to the Spindle team for the invite and fantastic presentation, Maureen. I work for Bill Graphica. We are a healthcare business incubator. And so we are also an impact investor. We've been in operation for around 11 years, just supporting healthcare innovations across the continent. I can see some founders in the chat, but we've also had the pleasure of working in different engagements with some good, experienced gentlemen in the ecosystem like Dr. Steve Adodans, who's part of the panel today.
Okay, thank you so much, all three panelists, for the introduction. I'm sure the work that you're doing will come out more clearly as we get into the panel discussion. And now I will start with our panelist, who is also a founder, Dr. Steve Adudans. Now, Dr. Steve, as you are thinking about Gear Health and the innovation that you are looking to bring into the health ecosystem, what problem actually convinced you that incorporating AI into the innovation was the way to go? How did you come up with that? What was your workflow like? And how exactly did incorporating AI seem like the next best step? Over to you, Dr. Adudan. You're on mute, perhaps, if you're speaking.
Apologies for that. Maybe it's AI. I'm just kidding. Now, it goes back to when I was attending to my mother about 6 years ago, and she needed a kidney transplant. And me as a medic, I thought it was gonna be easy. It was not as easy. So one of the things that I noted during that time was time to diagnosis and time to care or time to treatment. That was average almost 2 to 3 years. And we didn't have that time because there was information that is scattered all over. There was hospital, they want this test. You go to this other hospital, they want this test. And what complicated it at the same time was COVID pandemic with lockdowns and all those things. So we struggled a bit, and I thought, there needs to be a way that people are able to get a lot of information in a much more cohesive manner, in a much more easy and not painstakingly hard. And that's when we started Gear Health, and Gear Health will make it easy for people to be able to access information, to see how we can reduce time to diagnosis and time to care, especially for non-communicable diseases, because these diseases are becoming much more common, and by 2030, we anticipate they should be a major issue in sub-Saharan Africa and even in developing countries. So for us, AI is if we can reduce even a single click with AI for a clinician and they have time to spend with a patient, then we've achieved something. And that's when we actually we made a mistake. Actually, to honest, we shall be honest. We made a mistake. What happens that we started with technology. For me, I'm a clinician, so it was what technology actually can work. Can we do things faster? So we developed an app that would make clients be able to maybe or order medicine, but he had a very low uptake because it was almost like a shop where people buy clothes. So it didn't have like what the problem was. And that's when now we stepped back and started just automating every step. So you book an appointment, you're able to get information as to what you need to bring, what you need to have. You can ask questions, with the agent. What do you need to to carry along? What is it about your condition and things like that. So, and the outcome that we wanted to see is that a patient should be able to say that this makes my life better. And a clinician should be able to say, this makes my work flow better. So those are the outcomes that we just wanted, and we saw many clinicians wanted that. A patient doesn't want to know, are you using AI or not? Are you using the best technology? No. All they want is to get better health. They want to get treatment faster, and they want to feel better. So those are the things that actually moved us to be able to see how we can adopt AI. And I liked what Maureen mentioned there. From the bedside and to the back room. So, from the bedside at the point of care, what are some of those things that we needed to ensure that the patient is able to experience without necessarily us looking at the screen? And right now, we can look at the screen almost half the time we have a patient, and that is not what we should be having. It should be a humanistic approach when it comes to patient care. We should be able to look at the patient, take care of them. Anything else that they need to interact with AI, let it be, out of that interaction and in a different setting. So clinical decision support, very important. If you can reduce one click, for a clinician so that they just get these flags and stuff like that, then that was something that we were really focused on. Back to you, Val.
Thank you so much, Dr. Adudance. And I like that as an innovator, you're admitting some of the mistakes that you made. And I'm sure from that you have learned and pivoted and now actually having a better innovation. So thank you so much for that, for telling us that from the beginning, you need to understand the problem first. And now, as I cross over to Dr. Ojwang, who sits at the intersection of clinical practice and these digital innovations that we're talking about. Dr. Ojwang, from your perspective, what tells you that an AI solution, perhaps that now has been implemented at AAR Hospital, what tells you that this innovation has been designed with the African patient in mind, with you as the clinician in mind, and not just around technology? Dr. Adudance has actually talked about how when he started, he will actually made the mistake of starting with the technology instead of the problem in mind. So from your perspective, what will tell you that this innovation has all these key people in mind? Over to you, Dr. Ojwang.
Yeah, thank you. Thank you, Valerie. Yeah, so it's very important that and I like what my senior has talked about there about practicality of the solutions that we provide. So in any situation, it's always good to start with the problem and to try and address what is it that we're trying to fix first. And once that has been identified, then it becomes a lot easier to provide a solution to it. And Steve, it's very honorable of you to actually have shared your experience, because sometimes we look at the end product, and a lot of the products in the market, especially in the earlier days, were designed in that way. But as time moves, what I've realized through my clinical practice is that the solutions that like Steve has said, the solutions that actually provide good uptake among us clinicians are the ones that they solve the actual problems. Let me give you an example. A patient coming in, there's a patient coming into a clinic, let's say in Nairobi. Chances are they're probably an insurance patient. How long does the process take? Because any technology should be able to save time, should be able to save lives, and it should be able to save money. Most importantly, to save lives. So a lot of patients do not have all the time to sit in a hospital, and one of the biggest frustrations is the waiting. So does the technology that is created, does it shorten that waiting time between the patient and the first interface? For example, does it accept things like the AI triage, which now a lot of setups are adopting, that help to shorten that journey, so that by the time the patient has come in to see the doctor, probably they've already been triaged, they registered at home, and already we know that they're hypertensive or diabetic, they need to go to the physician's clinic, for example. That really shortens the journey quite a bit. And in addition to that, the solution needs to be friendly also to the person using it. One of the earlier uptakes in AI was in radiology, for example. And a lot of the solutions, the ones that have stood the test of time, have been the ones that have been able to iterate very quickly, to have interoperability with other systems, so that when you want to plug it in, let's say into an EMR or a health HMIS or health management information system, then it's a plug and play. So the ones that have really stood the test of time are the ones that have been very agile and adaptable in terms of being able to be interoperable, including with lab information systems, for example. Because as a hospital, for example, as an institution, instead of having 4 solutions or 4 different platforms that are all not speaking to each other, it's very important to have an opportunity where these can then be synced to each other, and to be able to work as a unit very easily. And a lot of the systems now are plugging into that. And maybe just to say, the other thing that we would trust would be something that solves, that preempts a problem, for example. Increasingly, the other day when we were having the Kenya Association of Radiologists conference, there was a debate about, do we allow equipment like CTs to be able to help in interpretation of images? The reality is that things are changing now. We have software that can help to read X-rays, for example. Does that mean they can read TB and they're perfect? The answer is no. Of course, that has to be validated. But if that triage can shorten the time, and also prompt the next phase of thinking in terms of diagnostic follow-up, for example, then that would be really a great solution. So the solution essentially also, lastly, has to be something that captures the entire customer journey, because at the end of the day, nobody follows up on patients, for example, who are patients who are diabetic or hypertensive. They need medication. Does anybody check on that? To make sure that they're linked up, let's say, with a pharmacy through telepharmacy or telemedicine platforms. So those are the solutions that would then ensure that there's an end-to-end holistic care, which is really what we're looking for as clinicians, because the intention is really to put the patient first. Thank you.
Thank you so much, Dr. Ojwang. That point on the innovation should be able to save time, save life and money, and most importantly, life. That's really the essence of why such a discussion is even important. So thank you for highlighting that. Now, from the 2 speakers, we've heard from Dr. Adudans, we've heard from Dr. Ojwang. So we've heard that founders are trying to solve, and what founders are trying to solve, and what the clinicians actually need, as Dr. Ojwang has so clearly said. And now, as we cross over to Emmanuel, when innovators come to you for help with an incubation process and acceleration, how important is an understanding of the healthcare problem when evaluating the actual startup? And what will really tell you that this founder understands the market and what they are trying to solve? Do they understand who they're actually trying to serve? As Dr. Ojwang has said, the patient needs to come first. Over to you, Emmanuel.
Thanks for that, Val. It's funny because I think there's a cross-cutting theme from what Maureen shared, what Steve Adudan said, and what Dr. Ojwang has actually shared. Because what you're actually describing around someone that really understands the problem, the other way to look at it is really somewhat building with the customer in mind. And in healthcare, the customer is not always, it's actually rarely one person. So you have a user. So for example, a clinician like Dr. Ojwang will be using the product. A hospital administrator would be the one paying for it. A patient will be benefiting from it. A regulator will be determining whether it actually comes to the market in the first place. And so that there is a problem that perhaps exists among all those people that the innovator would actually be trying to innovate for. And so it's proper to actually make sure that as a founder, you then understand all those elements and you're building around that. And I could even go further and talk about fitness because Maureen earlier on talked about different levels of fitness, and you can look at it from, you mentioned problem. Are you solving an important healthcare problem? She rightly said that, not all problems actually require AI as a solution. So it needs to be that you are applying AI because it's necessary and not just because it sounds cool or it's the in thing in 2026, for example. She talked about workflow, which is also part of really understanding the people that you're actually innovating for, which also, like I said earlier, forms part of that understanding of the problem, that it actually would make the work of clinicians easier, right? And the healthcare workers that are actually using it will find it easier to use it rather than, it won't be introducing new tasks or inefficiencies in their daily workflows. I think the other thing to mention is that is also part of this understanding of the problem and why it's important is around being able to demonstrate that actually your solution or whatever you're trying to build is accurate and useful, and it points to evidence, and that it's actually really safe and it can be applicable in real settings, and that at some point people have an incentive, right? They have an incentive and the ability to pay for it. So I do think why it's important to understand this is because from our side, because we are entrepreneur support organizations, oftentimes we need to select companies that we work with. Oftentimes we face situations where we introduce these companies to market partners like governments, other players that would help these companies scale across the continent. And it's solutions that actually, or it's founders that actually understand these things that are actually able to make it in the market. And so it's really, really important to build for the right problem or for the right people or build with them in mind. Actually, if a founder doesn't have a mix of the technical capability or a technical understanding and even a clinical understanding, especially in the healthcare space, oftentimes they are innovating something that is completely off, especially if it's touching that hospital context or clinical context as well. So I do think it's really, really important for you to be able to penetrate this market or this industry. You really need to fully understand the people you're building for, because that understanding actually enables you to develop a product that really aligns with everybody in that sector. Clinicians can use it. Administrators can actually buy it because it's relevant for that context. And people like us, investors, would be able to invest in you because it's really then, speaking to or pointing towards an actual problem that exists and that it's really needed enough. It's solving a problem that is big enough to warrant a few people to pay for it, right? It's not just a big problem, or it's not just a problem, but it's big enough that actually people are willing to pay for it, without which we don't think that a startup would be successful in the sector.
Thank you so much, Emmanuel. I like the aspect of building with the customer in mind, and the customer is not always one person. It's not always the patient at the end.
Yeah.
And now we'll go back to Dr. Dudans, and based on everything that we are hearing, what has surprised you as the innovation of Gear Health has continued to grow, and how you came up with the technology and the problem now that you're trying to solve? What has surprised you when implementing the innovation? What aspect of that? Is it actually the uptake, or how the clinicians are using it, or the uptake from the patients?
I think the biggest surprise is who pays. So And that, as Emmanuel has mentioned, healthcare is complex, and healthcare always, when it comes to technology, picks very slowly because it's multiple layers, just multiple layers. You see, when transport was adopting technology to going to checking in online and all those things, healthcare, we were still doing a lot of diary appointments. Okay, we're still doing diary appointments. You go to a doctor's office, there is somebody there to tell you, okay, when do you want to come? Anafungua diary. They open this book that is old, like a black book. We put your name there, what time, and all those things. So it is taking a lot of time because the question is the payment. And for many of us clinicians, because the payment and who pays and all those things, automation becomes a multi, layered because those who process payments actually have their own system and they don't want to integrate with other systems. Countries that have moved ahead have a much more unified system that everybody just buys into. Okay, so what surprised me is we have so many systems. They are doing many things. We've never had a harmonized back office, and that continues to actually be a surprise to me today because and we haven't reached a place where there's harmony like an orchestra on the background. We are all singing different voices because we want different things. The clinician wants different data. The insurance wants different data. And similarly, the patient just wants to be taken care of. So that has created a lot of big oops and challenge when it comes to automation because we can even you can even have a system. You propose it to insurance agent or insurance company, and they're gonna subject it to cyber security. So that's the other thing. So one of the other things that was a challenge was where do you store this data? Is the data because now when I go online and I see somebody breached Gmail and Gmail information, so I'm wondering where can I store patient data because healthcare data and patient information in terms of hierarchy is at the top. Okay, people are happy to share their boarding passes or on social media. Say, okay, this is NBO LHR, but nobody is gonna share their lab reports on the social media. And that's the thing about healthcare. So information about healthcare is highly guarded, and storage was another surprise. We just don't have affordable places to store securely healthcare data. Some of this big tech already do have where they say it's a HIPAA. So HIPAA is very American. So Healthcare Information Portable. It's part of the Healthcare Information Portable Something Act, which protects patient data. For us in Kenya, if I may use Kenya specifically, we do have the Kenya Data Protection Act of 2019, which protects data. So, but there is no storage of data locally where people have gone to the extent of what HIPAA does have. They store that data with every other data that is there. So that was a surprise. I would say those are the main surprises that we've had trying to go paperless.
Okay, that's really interesting. The comparison of we are ready to share our boarding pass and our lab reports, not so much. So that's really good. And what you've said about who pays, that's always a challenge, I believe, for most founders in this innovation ecosystem. And now, as we move to Dr. Ojwang, if you can share what separates an AI tool that clinicians will actually use from one that they will just quietly stop using. And if you can also share an implementation challenge that innovators are overlooking as you link it to why clinicians are not perhaps taking up some innovations, they are quietly just not using them. You can share briefly as the time is really also
Yeah,
running
thank
out.
you. Yeah, thank you. Yeah, so I think in terms of the tools that somebody would be willing to quickly use, or rather to use, and has to provide a solution, a practical solution, as we had talked about earlier. It has to be the ones that have succeeded are the ones that are iterative. Iterative meaning that there's continual development. And in the African space, in this era, as a founder, I believe the ones like Steve has mentioned, and I believe he has a whole team behind him. And that really what leads to the success when you have a solution that can easily iterate with the times. Because giving an example of one HMIS system that I've used before, I could tell when they started that these guys were going to grow super big, because I mean, from the word go, they were very keen on data protection, which is a very important thing. They were very keen on being adaptable. For example, they were very good on the customer journey side, but the finance was a bit needed a bit of pruning. So they were able to do that. And because of that adaptability, then right now they're one of the major players in the market. And I mean, it's really admirable. Of course, they've been quite stretched in terms of offering that personalized support. So it's one of the challenges now that happens with scaling solutions, especially once they're adaptable to the Kenyan market. The solutions need to be there needs to be movement, or rather growth that. And growth comes with people, it comes with resources that matches the growth of the solution that is provided. So that is one very practical thing that has allowed success. The other one that has allowed success is buy-in from key partners. Because, for example, I think it was a bit at the beginning where the CEO talked about even partnering with government entities. That's very important because, for example, if you get one major, if the product is so good that it can be able to, and I think Emmanuel also mentioned it, that it can be able to sell to one major player in the industry, then that allows for ease of scale. Anyone who sells to government is like to get a lot of buy-in. Maybe just to chime in on the challenge of interoperability that Steve had alluded to, gladly now following in the footsteps of India, and I believe, I think Nigeria has also just passed the law. In Kenya now, what the challenge was before was the data, the digital superhighway that would allow, the law that would allow to back interoperability. So now the providers have, and the users as well, have been compelled to have solutions which are adaptable to the to Taifa Care, for example, and to the Digital Healthcare Authority standards. So what that means is that essentially most of the solutions, be it in telemedicine, telepharmacy, be it in customer journey platforms, be it in service as a medical device, so all those have now a legal background to be able to talk to each other through an integrated system. So that is hopefully within the next 1 or 2 years, it's going to reduce the headaches that the earlier founders have had to go through. So that makes it easier, but it also presents an opportunity because the early adopters are the ones who are likely to benefit from this opportunity that now forces everyone to be adaptable. So it's either the system blends in or not. If they don't, the system does not blend in, the solution does not blend in, then it poses a challenge. So that is both a challenge with a potential solution. The other challenge that I've seen is the financing aspect. We've talked about governance already. So in terms of finance, I would look at a solution that is that fits both the user from a sustainability perspective, but also now that we've mentioned that, we've come across solutions whereby you could tell that they were stretched because the solutions could not scale, yet they had a very large addressable market. So that, and I'm glad that we have a finance expert here, because that then needs to match, the resourcing needs to match the growth of the platform. And together with the right people in the right seats, then it's possible to be able to scale such models. So from a user perspective, the ones that are really growing as well have been able to integrate easily with other platforms, because you can build a very expensive system and yet the service or the user changes the system simply because somebody else came and provided a more holistic solution. Let me give an example of ChatGPT and cloud. So for those of us in the audience, if you haven't used cloud, we will not shoot you, but we're just saying that you really should try it out, because it's like having everything else mixed in one, and you know, they keep changing it. There's something even more superior to that. So cloud essentially means that, or rather, solutions that can integrate all these tasks into one, can integrate laboratory services, can integrate imaging into one, can integrate the customer journey and follow-ups, can integrate dispensing of medicine, can even integrate medical devices, monitoring for patients at home, for example. So those really would be the ones that stand out in the market. And if we don't innovate as a healthcare industry, there are other people who are busy. I know some of them are, of course, in this audience, and we are welcoming everybody. Time is, we really need to work together. It's not a competition. We need to work together so that with this synergy, then we can actually provide solutions that are next level, with the right market, right tools, right people, and the right resourcing that comes along with it. In addition to good governance. Yeah, thank you.
Thank you so much, Dr. Ojwang. I like that point on we need the buy-in from all the partners and also the interoperability, and especially your point on adoption actually brings me to the next question to Emmanuel. So we know that adoption is something that investors and other ecosystem partners pay close attention to. So when assessing such startups, how much weight do you place on the customer adoption, as Dr. Ojwang is saying, and even Dr. Adudans was alluding to? How much weight do you place on the customer adoption, the clinical validation, and the actual real world evidence? Emmanuel, you can just share that briefly. And also, I can see some questions in the chat box. Kindly to the speakers, if you see a question that you can answer, just type that as a response. We might not have time to actually read out the question and have you speak to it. So if you can just respond to the questions on the chat. Over to you, Emmanuel.
Thank you so much, Val. I hope you can hear me. So let's start with adoption. I think adoption is really, really important, because without that, you then don't have people that are actually using your solution. And from Ville Graphica, or at Ville Graphica, we strongly believe in African challenges in healthcare being solved by businesses that are actually out there making money, sustainable businesses that are making money. So it is for profit entities that have innovated and developed solutions that have gone out in the market, and people are actually paying and adopting them, right? They're paying for that actual solution. So without adoption, it's really not attractive to us, because why would I put money in? Essentially what that means is I am interested in impact. We are all interested in impact, and less on the commercial aspect itself. And you are not able to actually get or get to the, some of the health outcomes that we would love to achieve as a company if people are not adopting or using your solution. And adoption in itself, there are just a lot of things. It goes back to, back to the points we raised earlier around building with the customer in mind, right? Or the end user in mind. And we said healthcare has all these people that you actually have to think about. The other thing that you talked about is evidence. I do think recently, a lot of investors now and people in this space are more interested in evidence. And I don't know whether I was the one who was not aware of it, and then I'm suddenly realizing, or I'm seeing it all over the place. But I remember back in the day, and back in the days, not so long ago, maybe 2020, there about 2019, we would assess businesses and look at how good they are and how good they sounded, and we would want to actually, support as many businesses as possible because healthcare innovations were not as many. But we're at a point where as entrepreneur support organizations and even investors, we have gotten burned. We've put money in places where people say this can do this, and it actually can't even do any of the claims that are actually being said or purported to be, to be doing. And so right now, we are really keen on evidence, and it's not just us because we are actually, our ticket sizes are quite small. We have investors that are giving big money, and one of the biggest things they rely on is evidence. One of our startups actually conducted, we funded them to do research with the Jomo Kenyatta University, and the outcomes of that, informed the addition of one business line within their company, and they got a huge investment from one of the investors we work with, and they were able to actually go into the public sector space, and they are currently implementing their project in Muranga. It all came as a result of evidence. The investment came as a result of evidence. So evidence plays a really big role in terms of helping a healthcare innovation really scale or really get adopted easily within the ecosystem. Because again, you need the funding from these guys to scale. I mean, a few guys are lucky because they can bootstrap and really make it within the system, within the ecosystem. But a lot of these innovations really always require some external funding to come in, and some of these things position a company really well to get external funding. I forget the third one that you mentioned. Yeah, I think I've talked about the adoption piece and the evidence piece as well. And the other thing I would
Yeah.
mention perhaps is around interoperability, which Dr. Ojwang actually alluded to. It speaks to adoption. A lot of interoperability is one of the topics that we are, as entrepreneur support organizations, we are now insisting on and really supporting our companies build startups, build innovations that are actually anchored on internationally approved standards. For example, for us, we are training innovators on fire standards because they are widely accepted across the continent. And what this actually does, it basically helps you not to be an isolated platform. You can easily plug in to existing systems in whichever market in the continent, and they're able to still speak to each other. So it plays a big role in helping an innovation again scale, especially digital health solutions. Yeah.
Thank you so much for that, Emmanuel, and especially for even telling us about the interoperability, about the fire standards, and actually insisting on the innovators you're supporting to actually have that as a big part of their innovation. And also the point that you mentioned about evidence being very key and what investors are looking at. You've also mentioned about no adoption. If there's no adoption, then everything is not attractive. So thank you so much for that. And now, as we just move into each of your call to actions and what you would want the participants to take away, I'll just nudge Kelvin to bring up the poll question that we had as the speakers are giving their call to action and their closing reflection on what they hope this discussion brings out in the innovations that are being built for Africa by Africa. We will have the poll question. And now, as the poll question is on the screen right now, kindly just have a read and give us your answer. And then I will just start with the closing reflection and the call to action from Dr. Steve Adudant. Over to you, Dr. Steve. Dr. Adudant, if you're speaking.
Thanks, Val. Yeah, definitely. I think a very, very refreshing conversation from the different panelists. Definitely with a kickstart from Maureen, just diving deep into how we can make AI adoption from pilot to practice. Also to what Dr. Zhuang has mentioned in the case of digital interpretation of imaging, and also at the workplace. Similarly, also Emmanuel from the venture capitalists and incubators perspective, that not everything that has a good idea, and especially AI, right? Everybody was riding on AI. So, you want to have funding, just say, and we're going to be putting AI into this. And, it sounds like it's a fad. So my take home, I would say that AI should reduce clinical burnout and not create digital burnout. So if that happens, then the patient outcomes are much better. So from my perspective as a clinician, let AI reduce clinical burnout. We don't want to click many times. We want to interact with the patient, and let it also not create digital burnout. Thank you.
Thank you so much, Dr. Dudans. Your key takeaway, no burnout. And now over to Dr. Ojwang.
Yeah, I think my takeaway would be to encourage us to innovate for the problems that exist in Africa. Africa is unique. We are a unique continent with unique challenges. That mother in Loitoktok, I like using this example, who has to travel all the way to Nairobi, or comes from Talek, deep down in Narok County. I was impressed the other day when I learned that there's actually a major hospital that is seeing patients there, and every day the specialists, they're triaged and they're sent to different specialists. And instead of traveling 5 hours to Nairobi, the patients in Talek, which is somewhere near Masai Mara, are actually seen by a specialist, queued normally, and are able to get a solution to their problems, and saving that money to buy medicine and for lab tests and other diagnostic tests that we need. So as we innovate, let's innovate for the solutions that exist, that clinicians will also appreciate, and it will actually solve the real burden that they have. Most importantly, let's also have financial sustainable business models that will actually draw in support and financial resources that would allow scaling. Thank you.
Thank you so much, Dr. Ojwang. It's about innovating for the problems in Africa. And now I will move to Emmanuel and then Maureen. Over to you, Emmanuel.
Yeah, thanks a lot, Val. I would just maybe add to what Dr. Jung has said. By all means, let's design this technology, but let's also design around, adoption around it. Think about the customers in mind, the people that are going to pay for it. Don't go to government with a business model that will not work within a government context, right? So design with the context in mind. And most importantly, I do think that the future is bright. If you guys had that circular that was released by Africa CDC at some time back, where they'd said, I don't know how many, 90-something%, having an ambition of 90-something% of digitally enabled PHC systems across the continent by 2035. And so if you think about that, and you have a digital solution that has AI in it, or even maybe doesn't even have AI in it, it means that over time, all these markets, all these systems that exist, including governments, are going to be open to actually adopting this. I know we still have an infrastructure problem, just thinking about the poll that came up. But at some point, there's really going to an opportunity exists for you with that digital solution to still plug in into that big market that there is out there. And so think about that adoption, think about interoperability. Let your solution be easily pluggable into an existing system, that it can easily be tweaked and work in another market because you followed like standards that exist. And evidence. Please generate evidence early. Back your claims, especially if you can back them up with certified institutions. institutions like research institutions like universities or these bodies that are providing certifications across to just make sure that, your claims are validated and they actually work. It gives everybody else confidence. Thank you.
Thank you so much, Emmanuel. And actually, the number is 90% of the number
Yes.
by Africa
Thank you.
CDC for primary
you.
healthcare digitization. Thank you so much. Over to you, Maureen.
I think my closing thought is really something that we see across a lot of our work as we do research and design in different contexts. I think the future of AI in African healthcare won't simply be determined by who builds the most capable model, the most technically impressive one. I think it will be determined by who understands the care problem and the care ecosystem the users deeply enough, who designs or creates their solution with the people that are expected to use that solution because you actually understand their workflow, their problems quite deeply, and builds the conditions for it to work beyond a pilot. Thinking around sustainability, business model, yes, you can get a model and use X number of tokens today. Are you going to be able to sustain that, at scale? So again, don't only design the intelligence, design the workflow, the human roles. And as you do all of that, I would say work on a problem that's big enough and that actually matters, not a solution that's chasing or that's looking for a problem. That's a much easier way to avoid a hairline recession at a young age, like the rest of us who went down the path of building solutions that don't actually have a problem. So look for a problem that actually matters and then dive into it with that in mind.
Thank you so much, Maureen, and a good tip for founders, as I am sure they scratch their heads. Good way to avoid that hairline receding. And also just reminding us to design the intelligence, not only design the intelligence, but design the actual workflows. So thank you so much, everyone, for joining the discussion. We are sorry that we are about 12 minutes over time, but we will leave the Zoom on for more interaction on the chat for you to just go through the chat. I've seen some very interesting discussion over there. And in case the speakers have not answered any of the question, also just feel free to follow us across our social media handles and reach out to the speakers on their LinkedIn for any follow-up questions. And thank you so much. And there are our social media handles. And thank you so much for giving us your time. I will just remind you that this is the first webinar in our 3-part series, and we look forward to continuing this conversation with you. And thank you so much for now. Goodbye from Nairobi and good evening.
Thank you so much.
Bye-bye.
Thank you. Have a good evening.
Thank you, everyone. Anyone who wants to remain behind to check out the chat will be here for just a few more minutes. Otherwise, thank you. And we have the poll results also. You can have a look at that. We will also share a brief report after this that will incorporate the discussion and even these poll results. Over.